And welcome to all you nonstop learners. We're here for a medical town hall. This is our number 4 for the summer. Nice to not see you. We will be moving at some point in the fall back into the auditorium when we can all come together again. But for now, I hope your life is opening up with more joy than sorrows. It's been an interesting year. We're going to talk tonight about strokes. As Anna said, I'm Dr. Ken Piper. I'm a retired internal medicine doctor and was starting my practice back in 1965. So I have seen strokes unfolding over decades. And I must tell you that we are in a really, really great place right now. And I think you'll learn a whole lot from Dr. Pandav tonight, because strokes are different. And one way they're different is we use the word brain attack. I want to emphasize that. You all know about heart attack. Hurry, let us help, open the artery, spare the heart. We're talking about brain attacks. Same kind of thing. Blood vessel closes, bleeds, brain tissues dying. So I want you to think about brain attack and the timing of letting us bring help to you by you coming to reach out and let us be here for you. Dr. Vijay Pandav is the director of the St. Francis Interventional Neurology Neurointervention. He does the magic things that you're going to hear about. And he does it with care and experience, and he's part of a team. Stroke management is not just the brain attack immediate, but what do we do 1 day and 2 days, maybe 1 month and 2 months later? So a comprehensive stroke center is just as important as this interventional component. And I'm going to turn it over to him right now and let him by the way, this is how it's going to go. He's got you now for a while. I'm going to be paying attention to your questions. So type them in. They'll come back here to my computer. I will raise my hand, bring the questions up to him, and we're just going to kind of work as a team together.
Good evening, everyone. Thank you, Dr. Piper. So my name is Vijay Pandav. I'm the interventional neurologist. I've been practicing here at St. Francis since 2017. And we became the comprehensive stroke center since 2017. So today I'm going to talk about stroke risk, prevention, and intervention. Before I start my talk, I want to talk about what is neurointervention, because it's a new field. So neurointervention is where we do minimally invasive procedures in the brain. So we go through the groin, we put a catheter in the groin and go all the way up inside the brain, in the blood vessels, and we do procedures there. And we use X-rays to do these procedures. So this is a new field. It has developed over the last 15 to 20 years. Before I start my talk on stroke, I want to start with 2 cases and just to say how important it is to know about stroke and how to prevent stroke. So my first case, and these are all real cases at our hospital. So 71-year-old male develops right-sided numbness around 10 p.m. He goes to bed, he talks to his wife, but he goes to bed, says he just ignores that. And this wife and husband sleep in separate rooms because of husband snoring. And the next morning, his wife goes and checks on him at around 10 o'clock and he develops complete right-sided weakness and cannot speak. So she calls 911, patient comes to the hospital the next day. Unfortunately, patient does not receive any treatment because he's outside the time window. There's a very specific time window for stroke, which we will talk in the future. But this patient came outside the time window. So this is what happened to him. This is a CT scan of his head. CT scan is, so everything on this CT scan, everything which is gray is normal brain. You can see my arrow, this is normal, how normal brain looks like. And everything which is dark is dead brain. That's the brain which died because of the stroke. So unfortunately, this patient died in the hospital. Our second case, so this is a 59-year-old female who developed right-sided weakness and speech trouble. She was with her husband, so her husband took her to the emergency room, brought her to our emergency room as soon as he's noticed the symptoms. So this patient in our emergency room, we do a CT scan and then we look at her blood vessels and we found that she had a clot in the brain. So we took her to our lab, which I showed in the previous image. We took her to the lab and we found that she had a clot in the brain. So this is an angiogram of the brain. All these black lines, these are blood vessels in your brain which are lighting up. So if you see my arrow, you see a blood vessel is stopped here. It's like it just abruptly gets cut off. That's where the clot is in the brain, and that's why that part of the brain is not getting blood supply. So this patient had a clot in the brain, and she was within the time window, so she got the best treatment. She got medicine to dissolve the clot, and she also got the procedure to take the clot out. And so this is after we took the clot out from her brain. And I will tell you how we do this in the future slides. So this is after taking the clot out. You see how the blood vessels are filling in that brain. And this is her CT scan. So again, everything gray is normal. If you see these two black spots here, that is her stroke. So when you compare this stroke to that previous patient's stroke, you know how small they are because this patient got the right treatment within the right time. So this patient did significantly better. Her symptoms resolved, and in 7 days she went home. So you see two extreme cases of stroke. One patient did not get treatment because he ignored his symptoms and he waited. He came the next day. And the second patient came in as soon as possible and got the right treatment. That's why stroke is a very important topic. Everyone needs to understand about stroke, and we need to get the treatment as soon as possible. So why talk about stroke? Almost 800,000 Americans each year suffer from a new stroke or a recurrent stroke. That's 1 every 40 seconds. Stroke is the number 5 cause for death in the United States. There's 1 death every 4 minutes, so it's a huge problem right now. So stroke causes a lot of disability. Patients who have stroke, they end up in a nursing home. They require total care for the rest of their lives. Many people lose their jobs. So this costs the nation almost 34 billion every year. And 80% of these strokes can be prevented. If you manage the risk factors, 80% of the strokes can be prevented, and we can save a lot of money and also decrease patients' disability. Unfortunately, 37% of the Americans cannot accurately identify even one warning sign of a stroke. So that's the reason we are trying to spread awareness about stroke. May of every year is the Stroke Awareness Month. So that's the month where we try to do most of the talks about stroke, and we try to educate people around about stroke. Going to the topic, what is a stroke? And I agree with Dr. Piper. I don't like the word stroke. It should be called brain attack, because then you can relate it to the brain. Now, when you just say stroke, what organ does it attack? So we don't know. So it should be called as a brain attack. As how we call a heart attack, it should be called as brain attack. But stroke is caused by problems with blood vessels in our brain. The blood vessels are the brain's plumbing system. So these are pipes which send blood to the brain. They send oxygen. The brain gets oxygen because of these pipes. So what happens with pipes? They either get clogged or they leak. Two things. So that's why there are two types of strokes. So the first type of stroke is called ischemic stroke. So ischemia is a Greek word. It came from the Greek word. Ischemia means stopping blood. So when a blood vessel gets blocked or clogged, there is no blood supply to the brain, and the brain cells start dying. This is called an ischemic stroke. And this is the most common cause of stroke. 87% of the strokes are ischemic in type. The second type of stroke is called a hemorrhagic stroke or brain hemorrhage. So what happens is the blood vessels start leaking and they cause bleeding in the head. And these are called as hemorrhagic stroke. And these hemorrhages happen most likely because of high blood pressure. You can see this picture of blood vessel starts leaking and it causes bleeding in the head. 13% of strokes are hemorrhagic. The reason being is over time we have controlled high blood pressure so well, so the risk of this hemorrhagic stroke has gone down. You also need to know about this term called transient ischemic attack or TIA, but people call it mini stroke. They always say I had a mini stroke. So what is a mini stroke? Mini stroke is a warning sign of a future stroke. So up to 40% of the patients with a TIA will have a future stroke if they don't address it. Symptoms of a TIA are similar to a stroke. So they are exactly the same, similar to a stroke, but they resolve within minutes to an hour, and there is no permanent damage on the brain or a CT scan. That's the reason it's called as transient. It's very important to seek medical attention if you suspect that you are having or have had a TIA, because 40% of these patients will have a stroke if they don't treat it. So coming to the topic about risk factors. So risk factors for stroke. So there are two kinds of risk factors for every disease. One which we can control, one which we cannot control. Ones which we cannot control are called non-modifiable risk factors. Age is one of the most common risk factor for stroke. As we age, our risk of stroke goes high. So after the age of 55, the risk of stroke doubles every 10 years. Sex or gender. So risk of stroke is higher in women, and it's mostly because of they have a longer lifespan compared to men. And especially younger women have a higher risk of stroke is because during pregnancy and postpartum they have hormonal changes. Their risk of stroke is higher during that period. And also young women take hormonal contraceptive pills. That also puts you at increased risk of stroke. Race and ethnicity. So African Americans are at twice the risk of stroke when compared to their white counterparts and have higher mortality with stroke. The reason being is these African Americans have higher risk for high blood pressure, and their access to healthcare is poor compared to other people. So there is a higher risk of stroke, and the mortality is higher in African Americans. Even the Native Americans have a higher risk of risk factors like diabetes, hypertension. So their risk of stroke is higher compared to Caucasians. Next, we go to modifiable risk factors. These are risk factors which we can control. And it's very important because the sooner we identify these risk factors, we need to control them to decrease the risk of stroke. So the first main risk factor is hypertension. This is the number one cause for stroke. Almost 50% of the patients with hypertension have a stroke if they are not controlled. So the goal right now is to keep your blood pressure below 140 by 90. 140 is the upper number. It's called the systolic. This is the upper number, and 90 is the diastolic, which is the lower number. The goal is we have to keep this below 140 to 90 to decrease your risk of stroke. So even a 10-point reduction in your systolic, like if the upper number is reduced by 10%, the risk of stroke goes down by 40%. There's a 40% reduction in stroke. So, we have a lot of medications to reduce your blood pressure, but behavioral lifestyle changes like change in diet, like low salt diet, and increasing physical activity helps to control high blood pressure. The next risk factor is diabetes mellitus. So diabetes can increase the risk of stroke by twofold. And almost 20% of the deaths in diabetics are because of stroke. And nowadays we're seeing younger patients with diabetes having strokes because of uncontrolled diabetes. And the longer you have diabetes, the risk of stroke goes higher over time. So if you're diabetic, you need to follow up with the doctor's advice, get your blood sugar level well controlled. So we normally measure this in the blood called hemoglobin A1C. This gives us a marker of your blood glucose in the past 3 months. So our goal is to keep this below 7 to decrease your risk of stroke. The next risk factor is atrial fibrillation. So what is atrial fibrillation? This is when your heart beats irregularly. So normally everyone's heart is beating in a rhythm, but in atrial fibrillation, the heart starts beating rapidly and the heart rate goes really high. But the heart is not beating actually, it's not pumping like what it's supposed to be. So the heart when it starts beating fast, it's not contracting completely. So the blood starts pooling in the heart. And when the blood starts pooling in the heart, it forms clot. So it's like a jello, when you start stirring it slowly, it starts becoming thick. The same thing happens in the heart. When the blood is not pumping out, it forms clots. And these clots break loose and go to the brain. And they cause a stroke. And the stroke risk increases 5 times if you have atrial fibrillation. So if you are diagnosed with atrial fibrillation, you should talk to your primary care physician and also meet a cardiologist, and we talk with a cardiologist and be on the right treatment. So patients who have atrial fibrillation, they have to be on blood thinners to decrease the risk of stroke. The next risk factor is dyslipidemia or high cholesterol. So when your cholesterol goes high, it causes blockage in your blood vessels. If you can see this picture, you see how as your cholesterol goes high, it forms like a plaque in the blood vessel, and the blood vessel starts becoming narrow. And when your blood vessel starts becoming narrow, so when the blood is trying to go through a narrow path, it starts there's a turbulence in the blood, and they can form small emboli, like small clots, and which can break loose and go to the brain. So these strokes normally happen in people who have high cholesterol. They have blockages in their carotids in the neck, and they form clots which break loose and go to the brain. So it's very important to keep your cholesterol under control. The goal is to keep your total cholesterol less than 200. Even in your cholesterol, in the total cholesterol, there are two components. There is a bad cholesterol component and a good cholesterol component. The bad cholesterol component has to be less than 70. It's called the LDL. That has to be less than 70 to decrease your risk of stroke. And there are medications to decrease this. But the good cholesterol, it has to be above 40, and that also helps in reducing your risk of stroke. And the way to increase your good cholesterol is exercise. The next risk factor for stroke is smoking. Smoking doubles your risk for stroke. Even secondhand smoke has shown to increase the risk of stroke by almost 30%. So smoking can affect anything it affects a number of organs in your body, but especially we've seen young patients who smoke have a higher risk of stroke. Alcohol. Heavy drinking increases the risk of stroke, but light or moderate drinking is protective against stroke. What do you call moderate or light drinking? For women, one or less than one drink per day. In men, less than 2 drinks a day is called light or moderate drinking. I don't recommend patients to start drinking if they don't drink, but heavy drinking definitely has an increased risk of stroke because it increases your high blood pressure, which can cause bleeding in the head and also can cause ischemic stroke. Illicit substance use, like use of cocaine, methamphetamine, these all cause increase in your blood pressure, and they put you at high risk of hemorrhagic stroke. The other lifestyle factors which contribute to stroke: physical inactivity or sedentary behavior. So people who are physically active have a lower risk of stroke and the stroke mortality than those who are inactive. Because if you're physically active, it helps in controlling your risk factors like your high blood pressure. It keeps your weight. It helps in losing weight, and that helps in reducing your risk of stroke. If you're physically active for 3 times a week, like if you do moderate physical activity or exercise 3 times a week, it decreases the risk of stroke. Diet. So diet influences the risk of stroke and also the risk factors for stroke like diabetes, hypertension, and dyslipidemia. Low salt and Mediterranean diet has shown to reduce the risk of stroke. So Mediterranean diet is defined as high intake of vegetable, fruits, legumes, olive oil as the principal source of fat, preferential consumption of fish and poultry over red meat, low dairy intake, and an option of low intake of red wine. This has significantly shown to reduce the risk of stroke. Lastly, obesity. Excess body weight and obesity are linked with an increased risk of high blood pressure, diabetes, heart disease, and stroke. So losing as little as 5 to 10 pounds can make a significant difference in your stroke risk. Any questions on risk factors so far?
Well, one question is, almost everything you mention in prevention is also being well, being healthy. One thing that's turned up is you're talking about conditions that affect all the blood vessels. I've had patients sometimes feel that, well, I've had bypass surgery, but that's the only place I have a blood vessel problem. But this condition, the blockage problems are everywhere. Legs, belly, kidneys, heart, and all up through. Can you talk more about the blood pressure control in terms of the long term? That's number one in stroke prevention. Should we be paying more attention to young people in their 30s and 40s now with blood pressure?
Yes, exactly. Blood pressure control it's the most common risk factor for stroke. And now the blood pressure goal has to be less than 140 by 90. That's if you never had a stroke in your future. So this is like primary prevention. So young patients, if their blood pressure is running high, above 140 by 90, should be on medications. And once if you have a stroke, right now they have reduced the blood pressure goal to below like 130 by 80. So that is secondary prevention. Once you have a stroke, your risk, you have to drop your blood pressure below 130 by 80. That's the new guidelines which came out last month.
And that upper number is the pumping pressure.
Yes.
So when that's 160, 170, you are pounding pressure up into these wonderful little brain arteries.
Yeah, and this pressure causes the blood vessels to harden and they start developing plaque, because once the blood is hitting these vessels, they start developing plaque. And that's when they cause blockages and they cause strokes.
So damaging those blood vessels with high pressure, with fatty stuff in the blood sugar management, the chemicals in tobacco, these are all addressable.
Yes.
Requiring consciousness and diligence. Okay, good.
All right, just to sum it up, so how can I prevent a stroke? So you need to control your high blood pressure as we discussed. Consume low sodium diet. Lower your cholesterol with either medications or diet. Lose excess weight. Get physically active. Follow up with your primary care if you have all the risk factors we discussed. And stay on your medications. Don't stop your medications unless you talk to your primary care physician. So these are all important things how you can prevent a stroke. So next, we go to the next topic is how do we identify a stroke? As I said, 37% of the people don't even know a single sign of stroke, and that's why it's very alarming. So the American Heart Association has come up with this acronym called FAST. It stands for face drooping, F stands for face drooping, A stands for arm weakness, S stands for speech difficulty, and T stands for time to call 911. Let's go in detail with this. So face drooping. So how do you identify a patient having a stroke? So the first thing you start with is ask the patient to smile, and you see if one side of the face is drooping. Or also ask if the patient has any numbness. So that is a sign of stroke, when your face is drooping on one side or you can't feel anything on one side. Then the next thing is you ask the patients to put their hands up in the air like this, as if they're holding a tray. And you see if the hand is drooping on one side, that's a sign of stroke. Okay, so A stands for arm weakness. Next is speech difficulty. So you see how they're talking. Is their speech slurred? Are they able to speak? Can you understand what they're speaking? Sometimes you can ask them, like, can you repeat the sentence? The sky is blue. So if they're having a stroke, they won't be able to repeat the sentence. Or sometimes if you tell them to follow a command, like, can you close your eyes? And if the patient can't close your eyes or he can't understand what you're saying, that means it's causing a stroke. So that's speech, S for speech difficulty. And the T in this stands for time to call 911. So if you see any person having any of these symptoms above, you need to call 911 immediately and they should go to the hospital. There are some other symptoms which I want to discuss about stroke. The other symptoms are like sudden numbness or weakness in your leg. So stroke does not affect your hands only, it affects your legs too. Sudden confusion or trouble understanding. When you have a stroke on the right side of your brain, those people, they get confused and they can't understand or they make sense. Sudden trouble seeing from your one eye or both eyes, that's also a sign of stroke. If you lose vision in an eye suddenly, you should be concerned. Sudden trouble walking, like if you suddenly can't walk, or you get dizzy, or you lose balance. That means you can't walk in a straight line, or you can't coordinate, like you can't pick up things. Those are all signs and symptoms of stroke, and especially these strokes happen in the brainstem or in the back of your head. And these are very important signs and symptoms. Sudden severe headache with no known cause. That's a sign that you're having bleeding in the head. So all these, if you have these symptoms, or if you see anyone having these symptoms, first thing is you call 911. Secondly, when you notice anyone having these symptoms, you have to record the time, because stroke treatment is dependent on time. So if you see this happening, you need to record the time when the symptoms started, because when the paramedics come to help the patient, they're going to ask, when did this start? So time is very important. So you have to note down the time. So why spotting a stroke and calling 911 is important? Because the sooner a stroke victim gets to the hospital, the sooner they will get life-saving treatment. Time lost is brain lost. So every minute, if you have a blood clot in the brain or if you're having a stroke, you lose 1.9 million brain cells. So every minute, 1.9 million cells are dying. And brain cells don't regrow. Like when you have you lose cells on the skin, they can regrow, but the brain does not regrow. So stroke is a medical emergency. So if you waste time, you're wasting brain cells. So you need to call 911. So I'll tell you what happens when you call 911. So if you see someone having a stroke and you call 911, so when the paramedics come and see the patient, and they say yes, he's having a stroke, so they alert the whole hospital. So they alert our system saying that we are getting a stroke patient to the ER. So that patient does not go to the triage. That patient who's having stroke directly goes to the CT scanner. So we save time by, the patient does not get any checkups. He goes to the CT scanner and we do a CT scan to see if there's blood on his brain or not. That's the first thing. So that helps us in saving time. Okay. And if there's no blood, then the patient goes to the next treatment. So calling 911 saves a lot of time by getting the patient directly to the CT scanner. What is the goal of treatment for stroke? So the goal for treatment of stroke is, basically stroke is like a blocked blood vessel in the brain. If you can see this picture, the arrow, there's a clot in the brain and there is no blood supply to this part of the brain. So the goal of treatment of stroke is you want to open that clot and you want the blood to go back to the brain. So that's the goal of treatment. I think there's some questions.
Yeah, one question is headache. Most strokes are a blocked blood vessel causing cells to die. Do those folks get a headache?
Yeah, most, especially young patients when they have ischemia, that is, they're having a stroke, it causes inflammation. As you know, they cause a lot of release of inflammation, like inflammatory markers, and they can cause headache. So headache is commonly associated with stroke.
But a stroke can be without warning. Something can happen suddenly. You may or may not have a headache. Older patients tend to not have headaches. I think one of your key points is if something's happening on one side of your body, but not the other, that's got to be the wake-up call. So I don't care, weakness, numbness, my hand's not working, my foot's a little floppy. Anything that's happening on one side of the body, but not the other, is what I've told patients for years. That is where you want to act. And when we call 911, that pushes the button here at the hospital.
Yes, yeah.
That gets the MRI team ready, you're ready. So we're just handling these brain attacks like we do heart attacks. Just.
We measure every patient with the stroke coming to the ER, we start the clock on. So every patient coming to the ER, we measure the time when he comes to the ER, when he gets a CT scan, when he goes to the lab, or when he gets the TPA. So everything is monitored, and we have metrics every month. We check, make sure we're hitting the goal. Right now, the goal is that the treatment for IV TPA should be given within 60 minutes. So if any patient gets it after 60 minutes, that's an outlier. So we have to work on those. We get the treatment as soon as possible.
60 minutes.
Yeah.
It's 1 hour for the clot busting drug.
So treatment options. So as I said, there are three treatment options for any patients having a stroke. The first is IV TPA. This is a gold standard drug for stroke care. This drug is designed to break the clot in the brain. The second treatment option is mechanical thrombectomy or endovascular clot removal, where we go mechanically and take the clot out from the brain and restore the blood supply. And the third treatment is medical treatment, where the patients are put on medicines like aspirin, Plavix to prevent further strokes. Let's talk about IV TPA. So IV TPA is also called as Clot Buster. So this is a systemic medicine. So this medicine is given in your IV to dissolve the clot. So as I was talking before, so right now the goal is to give this treatment within the 4.5 hours from symptom onset. Okay, this is the 2018 stroke guidelines. So if the patient comes in with symptoms within 4.5 hours, they should get this treatment. And this treatment so the goal in the hospital is as soon as they hit the emergency room, our goal is to give the patient this treatment within 60 minutes. And right now we are even trying to target it before 45 minutes. So the earlier we give the treatment, the better the chances of patient recovery. Because studies have shown that patients who get this Clot Buster medicine have 30% chance of doing better compared to patients who don't get it. But unfortunately, only 8% of these ischemic stroke patients are eligible for TPA. Because TPA has a lot of contraindications. That means you can't give medicines to some patients who have history of bleeding in the head, or who had a heart attack recently, or who have like bleeding from their belly, those patients, we can't give TPA. Secondly, if they had a surgery recently, like within 7 days, if they had a major surgery, they can't get IV TPA, because if you thin the blood out, it causes bleeding at other sites. So there are a lot of contraindications for TPA. So unfortunately, only 8% of these patients get IV TPA after coming to the hospital.
We have a question that I think is interesting. Emphasize that you call 911, the team arrives at your house, and they immediately put things into action. If you're in a stroke management system like at St. Francis, you're not going to go to a waiting room. You're going to be taken right into the system, right into the MRI.
Yeah.
So another important reason to call and get evaluation.
Yes, as some of the stroke patients require oxygen, they require some treatment before they come to the emergency room. Like some people, if they can't breathe, they have to get intubated. So when you call 911, they identify all these things, and they get IV access, they get patients on oxygen, and they directly go to the CT scanner. They don't wait in the waiting room, and then there's no triage. So sometimes in triage, there's a line, so things can be missed. So, but stroke patients don't go through triage. They directly go to the CT scanner. And in the CT scanner, the doctor comes in, the nurse comes in, the neurologist or the stroke team comes in, and they start evaluating immediately. So there is no wait. There's no wait for these stroke patients. In fact, any patient on the CT scanner has to be offloaded for a stroke patient, because that is priority. Trauma and stroke are the two priorities in the emergency room right now for CT scanner.
And what about Hillcrest and St. John's Ascension?
Yeah, so all comprehensive stroke centers follow this protocol. This is just part. So right now, St. John's, Hillcrest, and St. Francis, V3 are the comprehensive stroke centers. So this protocol is followed by all the major stroke centers. Even the small stroke centers which are coming up, they have to also follow this protocol, so that they give the IVTP as soon as possible, because this is all time dependent. So if the patient comes to triage, and if you keep let them wait in the triage, they're going to lose time. So right now, all the stroke patients, no one waits in their triage. They directly go to the CT scanner.
Well, I think this is worth just repeating. This is you worked hard to create this program, but in the Tulsa area, 911, mark the time, stroke, brain attack, in action, 3 hospitals waiting for you, systems in place, comprehensive programs. So we're in a good place in Tulsa.
So IVTP is the first intervention we have since 1996. So now, I'm going to explain about what is a large vessel stroke. So this is just part of the stroke, but when you have a big blood clot which goes to the brain, it's called a large vessel stroke. And 40% of the ischemic strokes are large vessels. So clot goes and blocks a blood vessel. If you can see in this picture, there's a red. You see this blood vessels immediately cut off here. That's where the big clot went and blocked it. So this is a large vessel stroke. These patients have high mortality. Like our first case I discussed, that patient died because he had a large vessel stroke and he could not get treatment. So they have a high mortality. So these patients, they need to get the right treatment. And IVTPA, when we give IVTPA, it cannot dissolve all the big clots. Only 10% of the big clots can be dissolved by IVTPA. So when IVTPA does not work, the next treatment we offer is endovascular options. So we take these patients to the lab, and we go through the groin and take the clot out. And I'll go over a whole case after this, okay? Just tell you something briefly about this endovascular option. It's called mechanical thrombectomy. So they started clinical trials in 2005, but unfortunately the first 3 trials were not successful. So this mechanical thrombectomy wasn't approved until 2015. That is 6 years from now, before. In 2015, we had 3 clinical trials which showed that mechanical thrombectomy was beneficial, and it should be done within 6 hours of symptom onset. So that's the reason. The earlier you come, you can qualify for this treatment, but after 6 hours, the benefit goes down of the treatment. And recently in 2018, we made the window larger. So some patients who come in after 6 hours but still can benefit from treatment were given treatment after they did a special kind of a scan. We do a special scan called CT perfusion. And if the patient meets criteria, then can get this mechanical thrombectomy up to 24 hours. But I again say, you don't have to wait till you come for 24 hours. You have to come as soon as possible. The earlier you come, the chances of outcome are better. Okay, I'm going to go over a case, like what we do. Okay, so as soon as you come to the emergency room and they find that you had a clot in the brain, you have a clot, you got your IV TPA, and they did a CT scan, they find a clot. So they call the neurointervention. That they call me or my partner. What we do is we take you directly to the lab from the emergency room. Our procedure is done under a local sedation or conscious sedation. We don't use any general anesthesia because we want to save time. Time is important, so we can't waste time. So we directly take you to the lab. We give you medicines to keep you sedated. So you are sedated. And then what we do is we puncture a blood vessel in the groin called the femoral artery. We put a hole there and put a catheter in that groin, as you can see on the picture. And then we take that catheter up from the groin all the way up into your neck. You can see this blue line, that's the catheter which goes all the way up into the neck. You can see the light blue spot, that's the clot in the brain. So I'm going to show you a video of. So this is a video, and if you see, the clot is going to come up and get stuck in the blood vessel. You see that black, this is the clot coming up and blocking the blood supply to the brain. So we identify that in the lab. We take it up and then we identify that clot. Then we go up with a small wire and we cross that clot with a small wire. And then we put a microcatheter. Microcatheter is like a thin tube. It's a hollow tube, and we cross the clot. After we cross the clot, we have to put a stent across the thrombus. A stent is like a metal tube with big holes in it. They're like pores. So you can see it now. You see how the stent is deployed across the clot. And as soon as we deploy the stent, it expands into the blood vessel, and it takes the size of the blood vessel. So what we give is we let the stent retriever stay in the clot for like 3 to 5 minutes. We let it marinate. We let the clot get stuck to the stent retriever. Okay. And once it is stuck, then we pull the whole stent retriever out. We pull that stent out with the clot, and you see in the video. Now you see the clot will come out, and we take it all the way outside the body. As soon as we take the clot out, the blood starts flowing back to the normal brain, and that's how we try to get the blood supply back to the brain. This is a case of mechanical thrombectomy. So again, right now we can treat with mechanical thrombectomy up to 24 hours. But again, you have to come to the hospital as soon as possible. You can't wait up to 24 hours. And this is a real case at our hospital. So this patient came in with a clot in the brain. If you can see on the second picture, the blood vessel goes and it stops there. Which is slightly bigger. So we cross the clot with if you can see this tube, we cross the clot with a thin tube, our microcatheter. You can see how big the clot is. You know, the vessel is not connecting between the two parts. That's the clot. This is our stent retriever there. We put a stent there and we let it marinate for 3 to 5 minutes, and then we pull it out, and you see how the blood vessel is now filling back. Before and after. And this is how the clot looks. And this is that stent retriever we use. So right now, IVTP and mechanical thrombectomy are the two treatments for acute stroke. So IVTPA was approved in 1996, and this was approved in 2015. It took us 19 years to develop a second treatment for stroke. So it is very important that everyone should get the benefit of mechanical thrombectomy if they have a large vessel stroke. The next intervention is, everyone thinks like, okay, IVTPA and mechanical thrombectomy are the two interventions.
Interestingly, a couple of important questions. I assume now that the EMSA teams in Tulsa and surrounding areas have been directly influenced by you and others into this new paradigm, because their job now is to make that diagnosis, hit the alert buttons, and roll to get that stroke patient into the hospital. So this is a new concept. They're not going to sit in your home and think about things, try to start an IV, and okay.
Yeah, we in fact, I and Dr. Hoover, we have EMSA teaching almost every other month. We go to EMSA teams, or even they come to our hospital, and we teach them about stroke, and we educate them about these procedures. Everyone in our state right now has been educated about these procedures. So, and EMSA also knows which hospitals have these procedures and which hospitals don't have these mechanical thrombectomy. So they know when they have a large vessel stroke, where to go. So everyone is well educated right now in the state. And our state has a team They keep educating this MSA team and even other paramedics about
This is a totally new way of looking at stroke.
stroke. Yes. So the last intervention for stroke is rehabilitation. This is very important. You know, right now people say, okay, IBTPA, mechanical thrombectomy, but I believe even rehabilitation is an important intervention for stroke. Because once your brain cells die, they don't regrow, but the cells around it can take over the function of the dead cells. And how do they take over the function? Is through rehabilitation. That means if patients, once they have a stroke, they need to be rehabilitated back to their normal life. And that's done through physical therapy, occupational therapy, and speech therapy. So when patients go through rehabilitations, their brain is getting stimulated, like they're doing exercises, and that helps in recovery. So rehabilitation is one of the most important intervention in stroke. This helps in patients getting back to their life. And right now we start rehabilitation as soon as possible. If you have a stroke today, you have physical therapy seeing you the next day in the hospital. They want you to get up and start moving sooner, because sooner the better. And this helps in recovery. That's it from my talk. I'll be happy to take over questions now.
Okay.
Thank you for your attention.
Thank you. Thank you. I'm still really impressed at the shift that's taken place in dealing with stroke, but it does come back to recognition. It's back to my brother, someone's mother, recognizing those early symptoms. I had some questions on prevention. We know that aspirin, a low-dose aspirin, can make a difference in reducing a clot in a heart artery. Well, what about low-dose aspirin? You didn't talk about that as a prevention technique.
So right now, primary prevention. So right now, if you don't have risk factors, they say you don't have to be on aspirin. Initially, we used to give patients aspirin to prevent strokes. But right now, if you have risk factors, like if you have high blood pressure, you have diabetes, then aspirin helps in preventing strokes. It helps in your platelets, it prevents your platelets from clumping to each other, and that prevents strokes. But aspirin does not prevent strokes in atrial fibrillation. So if you have atrial fibrillation, aspirin will not prevent those strokes. Those patients have to be on stronger blood thinners like Coumadin or the newer medications called Eliquis, Xarelto. But right now, primary prevention is a very hot topic. Right now, you don't start them on aspirin, all those patients on aspirin, unless you have risk factors.
Okay, so primary prevention means you've got no medical trouble, you're 50 years old, you're worried about stroke, we do not put you on aspirin.
Unless you have this.
But as we look at your whole balance, if your blood pressure is elevated, we're going to work on that. Cholesterol, a statin most likely. Aspirin would be part of that program for heart and brain attack prevention. So there's a lot of folks who are going around and getting these carotid artery screenings. And you mentioned if there's plaque building up in the neck arteries, bits and pieces can break loose and go shooting up in the brain. So question one, what do you feel about this carotid screening program that's available?
Sure, it is a good way to find out if you have blockages in the blood vessels or not, because they are at risk of stroke. But right now, medical treatment like aspirin, atorvastatin, or statins, they prevent it from getting worse. But you don't require any surgery or stenting until your blockage is a certain percentage. So right now, unless it is 70%, they recommend medical treatment is better. So if you have a blockage which is close to 70%, they recommend you need to be on aspirin Plavix. But if it is above 70%, they recommend you need to see a surgeon to see if you need to clean it or you need to put a stent there. So right now, it is important. If you have risk factors like high blood pressure and diabetes, the best way to screen for that is, when the physician just auscultates and sees if there is a turbulence or not. So that's the best screening test. And after that, ultrasound is the second screening test to see if you have blockage or not.
Okay. So St. Francis has had a carotid screening, abdominal aneurysm sonogram, and a leg blood pressure evaluation. Those kinds of screening tests are available now for patients, not through their doctor, but just through self-pay. What about atrial fibrillation? it's an increasing problem in our older patient population. Many folks do not know they're fibrillating. So when that fibrillation occurs, that's the bigger clot. It's going to be the bigger stroke. Those are the scary ones. Those beautiful slides you show of just taking out an entire big artery. Can you get out the little bitsy pieces that come from a carotid?
So unfortunately not. So when these small clots from the carotid come, they are very small. They are like microemboli. Those clots, you can't see them. Most of the time they can't be seen. So they cause strokes which are slightly smaller compared to the big clots. And sometimes most of these strokes are silent strokes. Like, if you do an MRI on these patients who have severe blockages, they can have like small strokes which were silent. They did not cause damage, but they eventually cause the brain cells to die. So those strokes normally we can't pull them out with thrombectomy or procedures. So for them to prevent those thrombi, you have to be on aspirin and a cholesterol medicine.
So if someone has a brain attack and the left arm gets numb, they come to the hospital, go through the procedure. In many cases, you're going to find, let's say, the blockage problem started in the neck, little pieces are breaking loose. That person then going to go on a very intensive long-term program, but probably not have a Clot Buster drug and not have a procedure done.
Yeah.
Yeah.
So those patients, if their blockage is above, so if you have a stroke and if the blockage is above 50%, the recommendations are you need to get surgery or stent, carotid stent.
Okay. So surgery to clean it out, a stent to open it up, but high enough blockage where the risk of the stroke is high and the risk of the procedure then is lower. So if that, I'm seeing a patient in the office and I'm told that a man a week ago had 20 minutes of his arm feeling numb and a little weak, and then it went away. That transient, we call it. How would you approach that in terms of working that patient up?
So those patients, I still, if I see any patient who has a TIA, normally I would tell him to come to the emergency room because he needs to have three things done. One is to look at his carotids, look into his heart, and look into his blood to make sure he doesn't have high cholesterol or he doesn't have diabetes. So I still recommend patients who have TIA to come to the emergency room and get evaluated because we can do this as outpatient, but it takes longer time. And I 40% of these patients are going to have a stroke. So if you get them to the emergency room and get them evaluated sooner, you can prevent those patients from having stroke. So I still recommend them to come to the emergency room. Some patients, they don't want to come to the, but my strong recommendation is if you want everything to be done sooner, you have to be in the emergency room.
So you would look upon this temporary, 10, 15, 20 minutes, my arm was numb, my numbness on my leg, I felt weak, I felt dizzy. You want to start that workup and you say this is not a brain attack in a major way, but now we know what we're dealing with, we're going to move ahead. Let's see, I think we've covered questions from our audience. Would you say a few words about aneurysms in the brain?
Sure. So aneurysms are, hemorrhagic stroke is a different topic. It's another 1 hour topic. So I didn't stress much on that, but aneurysms are like balloons or bubbles in your blood vessels. So they happen because of a defect in your blood vessel. And it can happen, it can be genetic or it can happen because of high blood pressure or smoking. So when an aneurysm, if it bleeds, it causes subarachnoid hemorrhage, which is like bleeding around your brain. That is one of the symptoms is like the worst headache of your life. That means an aneurysm rupture. So that's the bleeding kind of a stroke. And we do treat those patients here at St. Francis. What we do is first is when these patients come to the hospital, we want to make sure there is no increased swelling buildup in the brain. So sometimes those patients get a drain to decrease the swelling, and then we go to the groin and try to treat the aneurysm by putting coils, or we do surgery where they take the skull out and they clip the aneurysm. So that is what we do for aneurysm patients.
So aneurysms are 10%, well, they're not 10%, but bleeding brain attacks 10%. And a bleed almost always causes terrible headache. I mean, the worst headache of your life kind of thing. Other strokes, the headache can be variable. Yeah. Okay. Let's see. Oh, a side question. Why does alcohol reduce the risk of stroke?
What they say, alcohol is antioxidants, and that helps. Low dose of moderation alcohol helps in reducing your lipids and cholesterol. That's how they've shown that it can help in reducing stroke. But it's not proven. It's not really sure, but they've said it helps in reducing your risk of stroke.
Another area to talk about is you mentioned that brain cells are dying. And when that blood supply is cut off, you're losing important parts of the brain. And they're not going to recover. But yet we see people after strokes getting better. Maybe not everything. Most folks have something left over in the speech and the walking and the movement. Why are people getting better? What's happening that we lose those brain cells and yet things get better?
So when the clot goes to the brain, there's immediate damage to the brain. Like some cells die immediately, but there are some cells around that dead tissue. They are in dysfunction. They are not dying, but because there's no blood supply, they are in dysfunction. So our goal is to save those cells. So that's what happens is when we take the clot out, the dead brain cells die, but the cells which were dysfunction, they recover. And that's how the symptoms get better. Because the cells around the dead brain, it's called penumbra. It's like an umbrella. It's like an umbrella of cells which are not working fine because the blood is not coming. But they are not dead yet. So the treatment, when we take the clot out, these cells recover. And that's why the patients get better.
So there's cells that are dead. And then there are cells that are kind of stunned.
Stunned, exactly.
And if we can get circulation back to them, then they've got a chance to recover. Well, what about this, what they call plasticity, the miracle of the brain finding another way to do it? Tell me about that.
Yeah, so what happens, so once the brain cells die, those function, that every cell controls something in your body. Like some cells control your motor. So when those cells die, but the cells around it, what happens is with physical therapy and all, they form new connections. They form new neurons. They're basically like electric channels. They form and they start taking over the function of the dead cell. So that's called plasticity. Like the normal cells try to take over each other's function. I'll take over your function, and they try to get the strength back. And that's how people recover too with stroke. And physical therapy tries to promote that. They try to make you work with that hand, and so that the cells around it take over that function. That's how the brain helps in recovery.
So there's the acute phase. We've got 60 minutes to get that Clot Buster going. We've got a little longer, maybe up to 24 hours to go after a bigger clot. It's all designed to work quickly and improve that circulation. And then the long phase is to help that brain adapt. And I know this is not our topic for tonight, but I've heard bits and pieces about using virtual reality, computer systems, and all kinds of new ways in physical therapy to help develop these new circuits to get folks to kind of force the brain to figure out what you're going to do and find a new way to do it.
Yeah, they're trying to stimulate the brain as much as possible, with this virtual reality. And so we have this transmagnetic stimulation where they try to stimulate the brain cells through magnetic fields. It's not proven yet, but they're trying to get this into stimulate the brain.
So stimulate the cells and then train the brain, get new circuits, find a way to make that hand work. Yeah, very nice. Anything else that you would like to put forth?
No, I think three things we need to be very important is time is important. So don't wait. If you're having a stroke symptoms, don't wait. Identify a stroke. Many people who don't know about stroke, they need to know about this. I think hopefully they learned something about signs and symptoms of stroke. So you need to identify and call 911. So these three things are very important, and we should keep repeating this every time we talk to anyone or any of our patients or any of your friends around.
And the risks are going to be increased if you're dealing with high blood pressure, high lipids, diabetes. These are factors now that can affect so many parts of our body. But keeping that in mind, kind of a stimulation to get on the optimal prevention program. We've got some amazing things to do. So I think we'll stop with that.
Thank you.
Thank you,
very much.
Dr.
Thank you,
Pandav.
everyone.
Appreciate it.